Now, the next presentation is on the role of ETV in selected patients, NPH patients, by Dr. Fundas from the University of Thessaly.
Thank you, Mr. Chairman, ladies and gentlemen. There is a part of my presentation that I think that we can skip it because there are things that we've already listened to. Is it loaded? So let me make some introductory comments before getting into the actual presentation. This study started as a prospective study at the Medical College of Georgia, where I was practicing before coming to Greece, and then was transformed to a joint project. So part of this study has been done in the United States, and part of this, the last part, in Greece. So I have to acknowledge my colleagues participating in that. There's no question that everybody is aware of the complexity and the controversial character of NPH, its actual diagnosis and its treatment. The complication rate of shunting is definitely lower than the one that is quoted on the slide in the modern era of programmable valves. However, it remains unacceptably high, and that's why everybody is looking for an alternative surgical method. I have to cite again the multi-institutional Italian trial, which was published on neurosurgery a few years ago. And the purpose of our study was, again, to select these patients that maybe be benefited from an endoscopic third ventriculostomy, patients suffering from idiopathic normal pressure hydrocephalus. By the way, that term idiopathic is definitely idiotic for us and pathetic for the patient, but there's no other way to describe that. So our inclusion criteria, taking into consideration the suggestions and the findings of the Italian study, we decided to include only patients that were less than 80 years old, had short symptom duration, less than 6 months, preoperative MMSE score higher than 18, CSF stroke volume on the preoperative CNMR higher than 42 microliters per stroke, symptom improvement, clinical improvement after a lumbar drain test, which consisted of draining for 72 hours 10 milliliters of CSF per hour. No other evident comorbidity in these patients, and no previous shunt insertion in this group of patients. So we ended up in a 6-year period of this prospective study to recruit 8 out of 134 patients, which is something less than 12%. You can see some of the demographics of these patients. I know that this is a really busy slide. However, I need to just emphasize a couple of things. Most of these patients had the typical triad of symptoms: gait difficulties, dementia, and also urinary incontinence, as you can see. And all of them had on their preoperative CNMR stroke volume higher than 42. In some cases, this was significantly higher, in some was marginally high. In some of these patients, there was a radionuclide cysternography, and in some other patients, there were ICP monitoring with characteristic big waves on their monitoring. Otherwise, their demographics were quite frequent for that group of patients. We employed preoperative evaluation with CT scan in all of these patients, and we calculated Evans ratio pre and post-operatively. And we also marked these patients with a Japanese NPH grading scale, which is a 12-tier scale. I assume that everybody is familiar with that scale in the room. And for the statistical analysis, although our numbers are low and the sample is very limited, we use the Kolmogorov-Smirnov test and the Spearman-Rank correlation tests. So, surgical procedure, I don't think that there was anything specific about that. Rigid, straight, zero-angle endoscope, right-sided approaches in all of these cases, bipolar coagulation, opening, and then a 5 French focal catheter for dilating the stomach. In regard to the operative time, procedural time was less than an hour in all of these cases. As you can see, minimal blood loss, and with irrigation we had no problems, and no intraoperative or immediate postoperative complications. Mean hospital length stay, less than 3 days. CineMR was obtained 4 weeks post-operatively. And then the mean follow-up time, as you can see, it's slightly higher than 3 years. The range was between 2 and 6 years. There were no shunt inserted in this group of patients post-operatively after the third ventriculostomy. There was no reason for doing that. And there were no other procedure-associated complications in our cohort. In the results, that's actually the most important slide of the whole presentation. There was improvement on the post-operative grade at 12 months. The measurements that you see are 12 months after the procedure. And this improvement was more impressive in the gait difficulties, as it has been described in the previous presentations today and also in the literature. The least responsive symptom was dementia, as somebody would expect. In addition, there was significant improvement in the obtained CineMR regarding the stroke volume and the aqueductal stroke volume, and also some slight improvement 12 months after the procedure in the Evans ratio. Performing statistical analysis in this, and please keep in mind